Welcome to this video on how to manage a bleeding patient at Randwick campus. When a patient is bleeding, usually there are senior team members present, but it is still important for everyone to understand what critical bleeding means and what they can do to ensure patients receive care as soon as possible. Often these situations develop very fast, and your help can be life-saving. Remember that depending on the situation, there are emergency protocols in place for hemorrhage, including in trauma and obstetric patients. It is important that we are aware of and follow these guidelines. At Randwick campus, we use the critical bleeding protocol. Some of you may be familiar with other terms, including the term massive transfusion protocol, or MTP. The first thing to remember is that at Randwick campus, you cannot call an MTP. You must call a critical bleeding protocol. It is also important to understand that when a patient is bleeding, they are losing red blood cells, but they are also losing other elements of their blood that help their blood clot. Treating critical bleeding requires replacement of red blood cells with packed red blood cells, but it also requires replacement of other blood factors to allow the patient's coagulation system to work. This can include platelets, plasma, and cryoprecipitate. We can call these other elements yellow products. Before we delve too deep into the protocol, in order to reduce bleeding, there are some physiological targets that we really should prioritize early in order to ensure optimum function of the coagulation system. By virtue of having activated a critical bleeding protocol, we should be preparing for infusion of large volumes. We must be proactive in maintaining normal temperature and calcium, and as best as possible, preventing acidosis. So let's go through what critical bleeding means and how you can determine if your patient is experiencing critical bleeding. To qualify as critical bleeding, the patient must be unstable from blood loss and be expected to need more than 4 units of blood in 4 hours. This may be because of significant trauma, major GIT bleeding, or obstetric hemorrhage. Once a senior clinician decides that a patient is having critical bleeding, we need to collect a set of baseline bloods. Remember to collect from a site without an infusion running. Or, if you have no other option, remember to pause the infusion for 3 to 5 minutes first. As an ICU representative on a code blue team, for example, you may be the senior clinician. We also need to tell blood bank so that we can get blood as quickly as possible. Blood bank can be contacted on 23232, and you must say, "I need to activate the critical bleeding protocol." Remember, you can't ask for an MTP. You will also be asked if you want a non-ROTEM or ROTEM guided protocol. ROTEM is a testing device that gives us more accurate information about how blood is clotting. We can use it to determine which of the yellow products are most needed, rather than giving the standard set. If there is critical bleeding, the patient is unstable, and there are no staff available to run a ROTEM, then we use the non-ROTEM protocol. ROTEM-guided protocols require a member of staff to run testing and a patient who is able to tolerate resuscitation with crystalloid and red cells while waiting to determine which yellow products, if any, are required. The ROTEM devices are located in the acute areas. The senior nursing staff will be aware of the procedure. Please don't use the ROTEM machine yourself. When you activate the critical bleeding protocol, regardless of ROTEM or non-ROTEM guidance, the blood bank releases 4 units of red blood cells for your patient. You must fill in this pink form for 4 units of packed cells and give it to a porter immediately so they can collect the blood from blood bank on level 4. This form can be completed by nursing staff and a new form is needed for each time you send for any blood product. As you can see, the critical bleeding protocol has two different arms. If you choose the non-ROTEM arm, you rotate between pack 1 and pack 2 until bleeding is controlled. The contents of these packs are standardized. In the first, you get 4 units of packed red blood cells, 4 units of extended life plasma, which is a longer shelf life form of FFP, and 3 units of apheresis cryoprecipitate. In the second pack, you get another 4 units of packed red blood cells, 4 further units of extended life plasma, and a bag of platelets. You can also consider giving tranexamic acid for any patient with clinically significant bleeding. This has been shown to be particularly helpful in trauma and obstetric hemorrhage. Now let's talk quickly about what ROTEM guided means. ROTEM stands for rotational thromboelastometry, and it measures the various mechanisms of clotting based on the time taken to form clots and the strength of the clot itself. The results are interpreted using visual algorithm guides to inform specific blood product administration. Most critical bleeding scenarios on campus are managed using ROTEM guidance, as long as there is a team member, usually from anaesthetics or ICU, who is ROTEM trained. Again, the senior nursing staff will be aware of the procedure, and please don't use the ROTEM machines yourself. If there is no one able to assist with the ROTEM guidance, as may happen on a ward or ED emergency, then the critical bleeding protocol first pack 1 of products, should be requested by asking for non-ROTEM critical bleeding protocol, and this administered while awaiting ICU assistance. This is a picture of a ROTEM machine. There are several on Randwick campus in the acute areas of ICU and theatres. Some areas without a machine have a workstation with information and cartridges. The ROTEM test should be run on the nearest machine as listed at your workstation where the cartridges are kept. Unlike usual coagulation tests which have to be sent to the lab, ROTEM is a point-of-care test that is run usually by nursing staff. To run the test, they need a citrate tube, which is the blue-capped tube you usually use for coagulation tests. Results are back quickly, usually in 10 minutes. The labelled blue top tube is taken by an RMO or porter to the ROTEM machine nearest to your area, usually in the theatre or cardiac ICU. It's a good idea to call first so a nurse can be ready to assist to run the test and return a sticker with the results to you by porter or phone. Be sure there is a plan on how the results will be returned to you. This is the graph the machine produces. It is a representation of the patient's ability to form a clot and shows the time for clot to start forming. This is called the CT or clotting time. We can also measure the strength of the clot, which is determined by the amplitude of the curve or how fat the sausage shape gets. This is measured in millimeters, and we use the A5, amplitude of 5 minutes. We can also look for unstable clot by looking at how quickly the clot breaks down over 30 minutes. The 4 squares are different measures of aspects of the coagulation system. Products are added to blood by the machine so that we can look at these different aspects. XTEM is a measure of the extrinsic clotting system and can be thought of as similar to INR. INTEM is a measure of the intrinsic system and can be thought of as similar to APTT. FibTEM tells us about fibrinogen function and is similar to a fibrinogen count. HepTEM is usually only used in cardiac cases and removes heparin to give information for patients who have been given large doses of heparin for cardiac bypass. When you use ROTEM to guide your critical bleeding protocol, the information taken from the graphs on the previous slide is used to determine which blood products are needed. Next to the ROTEM machine is a sticker that you can see on the left. The nurses will fill this sticker in with the numbers taken from the graph. The relevant green, orange, and red ranges should be chosen and circled, giving immediate visual feedback if there is a result in the red range. This is one of the Randwick campus algorithms. The numbers on the sticker are then compared with the algorithm to determine which products are needed. The protocol has been designed as a traffic light system, where red means something definitely needs fixing, and green means there is normal coagulation. We do not usually treat results in the orange zone. They are considered adequate for hemostasis. With significant bleeding and coagulation in the green or orange zones, surgical intervention may be required to stop bleeding. For each step in the algorithm, you use the number on the sticker to determine if there is a problem with that part of the coagulation system. A key aspect of the design of the algorithm is that if there is a problem, you stop and fix it with the appropriate treatment, then retest. You may frequently find that correction of issues identified early in the algorithm will improve apparent parameters further down the decision tree. In other words, don't look down the pathway and correct multiple factors at once. The sticker must always be completed and, where possible, placed in the patient's notes, such as on the back of the anaesthetic chart, with your management plan included. Sometimes your plan may vary from the algorithm if an adjustment is considered necessary by a consultant clinician, and if this is the case, please document this. Be aware that there are different algorithms for different patients post-cardiac or vascular surgery. These patients have received large doses of heparin and may require reversal with protamine. There is also a different algorithm for Sydney Children's Hospital to be used in children with critical bleeding. The major difference is that doses of products are given in mils per kilogram. So let's use a clinical example to show how the algorithm works. A 25-year-old woman is brought in by ambulance to ED following a car accident. She is pale, drowsy, tachycardic, and hypotensive. Her fast scan shows significant abdominal bleeding. She is taken to the operating theatres and a ROTEM is performed. After filling in the sticker and circling general algorithm, we then consider her ROTEM numbers. Her XTEM A5 is 21. This is in the red and hence abnormal. Her FibTEM A5 is 3, which is also red. Her XTEM CT is 118, which is also red. Now let's look at the algorithm to see what this means we should do. Starting from the top, she does have clinically significant bleeding. Remember, you must have significant bleeding to perform a ROTEM. Now the first step asks for the XTEM A5. If the number is less than 35, it suggests that there is hyperfibrinolysis. This can be treated with tranexamic acid, if not already given. Sarah's XTEM is 21 and she is a trauma patient, so we would definitely give tranexamic acid. We then move on to the next step, which tells us if the fibrinogen is low. In most cases, especially trauma, fibrinogen is low because it has been consumed by the coagulation system. If the Fib10 is less than 12, fibrinogen is low and should be replaced. The lower the number, the more fibrinogen the patient needs. In our case, Sarah's FibTEM is 3, which is very low. Given this, she needs 12 units of cryoprecipitate to replace her lost fibrinogen. In the rare instance where there is no time to wait for cryoprecipitate to defrost, a senior consultant may authorize the use of fibrinogen concentrate. In this case, 8 grams of fibrinogen concentrate would be the appropriate dose. Please consult your senior consultant before considering this, as they will know whether this is possible. Given that we have identified a problem, we now stop and treat that. We then repeat the rotum 10 minutes after giving all of the cryoprecipitate or fibrinogen. Ten minutes later, we repeat Sarah's rotum, which is shown above. As you can see, both graphs look much thicker now. Often when you fix one aspect of the coagulation system by giving fibrinogen, other measures will improve as the system works better. This is why it is important to use the algorithm in a step-like approach. Now we can see that Sarah's XTEM A5 has improved to 59, her FibTEM A5 is 23, and her XTEM CT is 51. All of these numbers are now green, indicating that Sarah's blood no longer shows signs of abnormal clotting. To summarise, at Randwick campus we use the critical bleeding protocol. It's not called an MTP, which should be activated in the scenario by calling 23232 and using the words critical bleeding protocol to the blood bank. This will facilitate 4 units of packed cells delivered to you, and initially you manage the bleeding with packed cells and crystalloid. Most critical bleeding scenarios on campus are managed using rotum guidance, as long as there is a team member, usually from anaesthetics or ICU, who is rotum trained. A blue top tube is taken to the nearest rotum machine, and a nurse there can be ready to assist to run the test and return a sticker result by portal or phone. You must not use the rotum machine yourself. If there is no one able to assist with the rotum, then the critical bleeding protocol first pack of products should be administered by asking for non-rotum critical bleeding protocol. Hopefully with the above protocol you'll be able to manage your bleeding patient successfully. Don't forget, when your patient has stopped bleeding, you must call blood bank to stand down the critical bleeding protocol. We hope this has been helpful and enjoy your time at Randwick campus.